My name is Pisano, and this is a presentation on how to use diagnostic ultrasound to read the long head of the biceps tendon. Throughout this presentation, I will discuss the anatomy of the biceps tendon brachii, along with the patient and clinician positioning, imaging, clinical considerations, and clinical significance of this process. The biceps brachii consists of a long head and a short head. Both of these structures are found on the photos to the right with labels for easier discretion. The long head originates on the supraglenotubercle of the scapula. The short head originates off the top of the coracoid process. Both of these tendons insert onto the tuberosity of the radius and the fascia of the forearm through the bicipital aponeurosis. These tendons are innervated by the musculocutaneous nerve and functions as the flexor and supinator of the forearm. The patient should be seated in an upright position with their arms slightly internally rotated and elbow flexed at 90 degrees. The examiner should stand in an orientation where both the patient and the ultrasound screen can both be seen. The transducer notch should be directed towards the patient's head in order to display a long axis scan. From the examiner's point of view, the left view matches with the ultrasound screen as a mirror image. The clinician should palpate the patient's bicipital groove to locate the biceps tendon. Moving the patient into passive internal and external rotation will help find the long head of the biceps tendon accurately. This view shows a long axis scan. The bright line at the bottom of the screen can be identified as hyperechoic and is the head of the humerus. The dip seen in the middle of this hyperechoic line can be identified as the bicipital groove. Superior to the bright line, we can see the long head of the biceps tendon, which can be identified by the striated appearance. In this frozen image, we can see the cortical head of the humerus at the bottom of the screen with the long head of the biceps tendon sitting superiorly. Here we see a video in a long axis view of the long head of the biceps tendon. The examiner can instruct the patient to actively flex their bicep to confirm that the transducer head is over the correct structure. We can see the movement of the tendon on a stretch as the patient actively flexes and extends their forearm. Here we can see a transverse view of the long head of the biceps tendon, which is superior to the head of the humerus. This view is helpful when looking at swelling and subluxation of tendons. The examiner can also instruct the patient to actively flex their bicep to confirm that the transducer head is over the correct structure, as seen in this video as well. Once again, we can see the movement of the tendon on a stretch as the patient performs bicep flexion and extension. In this frozen image of a transverse scan, we can see the intertubercle notch of the humerus at the bottom of the screen and the tendon sitting superiorly. An important clinical consideration to remember is anisotropy. This is the property of being directionally dependent and is important to remember when performing diagnostic ultrasound of a tendon or nerve. The clinician must keep a 90-degree angle between the probe and tendon during this evaluation. Angling the probe back and forth along the axis of the structure will cause it to appear darker and less distinct when the transducer is no longer parallel. It can alter the echogenicity of the image, mistaking a normal tendon for a partial tendon tear or other pathologies that are not present. Diagnostic ultrasound can be utilized to rule in or out injuries to the long head of the biceps tendon as well. These injuries include full thickness tears, bicep tendonitis, bicep tendon dislocations, or bicep tendon subluxations.